Thanks, Angie, and thanks for that lovely intro. Like Angie said, I am recording this, but I am also here today, available to chat with you. Please send me your questions when they occur to you so that I can get to them before the presentation ends. So I look forward to chatting with you. We are going to talk about precision cardiometabolic lab markers because heart disease is the leading cause of death worldwide. And the heart is responsible for providing blood flow to all of the organs, including the brain, which is necessary for cognitive function. So if we want to live long, fulfilling lives, we need to think about taking care of our cardiovascular system. The standard lipid panel includes calculated LDL, but this provides only a crude estimate of a patient's atherogenic burden, and it serves as a tool to decide whether or not to prescribe a statin. But some patients with normal LDL are still having heart attacks. Cardiologists are now recognizing particle number as potentially a more accurate indicator of risk than just traditional lab markers. And we're going to discuss this along with other modern precision lab markers of cardiovascular and metabolic risk to give you an early opportunity to turn someone's health around. What is the first sign of coronary artery disease? In some cases, it can be having a heart attack. In other cases, the first sign can be death. That's why it's the silent killer. Patients often don't know they have hyperlipidemia. We need to educate patients to improve their health literacy, make sure they understand how to prevent heart disease, make sure they understand what their risk is, and that they know how their labs inform us about that. Metabolic syndrome increases the risk of cardiovascular disease. Renal health, if it is impaired, can lead to hypertension, which also increases cardiovascular disease risk. The liver is responsible for metabolizing lipids, so we also need to pay attention to liver health. Early detection and reduction of risks is very important because once these conditions increase in severity, it becomes harder and harder to treat. Gut health comes into play. If someone has IBS or intestinal permeability, then they're going to have impaired nutrient absorption. They can have deficient minerals that can lead to cardiovascular disease. And lastly, exposure to plastics can lead to nanoplastics in the carotid plaque, and that can increase the likelihood of MI, stroke, or death by over 4 times. The biggest risk factor for atherosclerosis and heart disease is increasing age. This is the one thing we have no control over, actually one of 2, that and family history. I would recommend screening all patients who are over the age of 50 and any patients who have significant family history. Patients on a standard American diet also, those with sedentary lifestyle, if they have central adiposity, if they smoke, if they're a heavy drinker, people with irritable bowel disease, if you know their cholesterol is high, and even hypothyroid. 45% of adults have fatty liver, and the most common cause of death in these patients is cardiovascular disease. And we used to call this non-alcoholic fatty liver disease, but it's now more aptly named metabolic dysfunction-associated steatotic liver disease. Sugar damages the liver just like alcohol. And as central adiposity increases, this can result in up to a ½ pound of extra adipose accumulating in the liver. Individuals with this condition will have at least one of the metabolic syndrome criteria on the left, and their liver can contain up to 10% of its own weight in fat. Fasting and weight loss can be an effective way to reduce the hepatic adipose accumulation. Fatty liver disease is associated with cardiovascular adverse events and risks, and cardiometabolic testing can identify additional red flags that we need to address to help tailor your treatment. Gut dysbiosis affects lipid metabolism. It can contribute to the development of fatty liver disease and cardiovascular disease. People with IBD who are between the ages of 18 and 24 have 9 times the risk of a heart attack compared to healthy peers. And even if they don't have traditional risk factors like hypertension, high cholesterol, or smoking. PCR stool testing might reveal more inflammatory phyla, less of the short-chain fatty acid producers, leading to compromised mucosal integrity. And this pattern is associated with diabetes, obesity, and cardiovascular risk. High-fat keto diets and even low FODMAP diets followed long-term can lead to these same high-risk microbial signatures. So think about doing a GI 360 on patients who have a really limited or a very different diet like this. Sedentary lifestyle and a diet of high in processed foods and carbohydrates can lead to abdominal obesity, dyslipidemia, hyperglycemia, and hypertension. And 25% of adults fit this criteria. We want to catch these individuals early to help prevent complications. And that would involve moving beyond a standard lipid panel, fasting glucose, and even hemoglobin A1C. These tests might fail to catch the high-risk patients, and if the results are not abnormal, then patients might not be motivated to change. What if your fasting glucose is 99? What if your hemoglobin A1C is 5.6? This is within the normal range, but there's definitely a problem developing. I don't like these numbers, and I think we're going to have to address the lifestyle in patients like this. But I think testing the more specialized markers can show the patient that something is actually wrong right now, rather than saying your labs are normal, let's wait till it gets worse. This would be a more comprehensive approach to identify risk early. Oxidized LDL can be measured on its own because it's an independent risk factor for cardiovascular disease. And then as far as LDL, some of the particles are large and buoyant. These are neutral to cardiovascular risk. Small dense LDL are higher risk because they can get into the endothelium and they contribute to atherosclerosis. Lipoprotein A will be relatively the same for a person's lifetime because it's largely genetic and it doesn't respond much to nutraceutical supplementation. This lipoprotein impedes fibrinolysis, it promotes inflammation, and it can contribute to plaque formation in the arteries. And your body is constantly making and degrading blood clots as part of a normal process called hemostasis. But if you have high lipoprotein little a, then you do not degrade fibrin as efficiently. You don't break down those clots as efficiently. Apolipoproteins A1 and B100 can tell you about the direct number of lipoprotein particles and help you compare atherogenic to non-atherogenic particles. And the Canadian Cardiovascular Society is now strongly recommending using non-HDL-C, which is total cholesterol minus HDL, or ApoB instead of LDL-C as the primary risk marker for cardiovascular, atherosclerotic cardiovascular disease. And 1,5-anhydroglucatol is an indicator of glucose metabolism. It can let you know if you have postprandial hyperglycemia episodes over 180. And leptin resistance occurs when we are eating when we're not full, when we snack too often. Also, the other adipokines, what's the other one? Adiponectin is kind of the opposite of leptin, and it represents better insulin response. ApoB is a more modern predictor of cardiovascular events. And this graph is showing you that among almost 300,000 adults in the UK, roughly half men, half women, the 10-year risk of atherosclerotic cardiovascular disease events was significantly higher with high versus low ApoB at nearly every level of LDL. If you're just measuring LDL-C to see if you've effectively lowered a patient's risk with treatment, you may be missing those with high ApoB who still have higher risk of a heart attack. And we'll talk about what ApoB is shortly, but first, what is cholesterol? What we call our cholesterol is referring to this collection of lipoproteins that are circulating in our blood carrying the cholesterol, and they're categorized by their various sizes and densities. Some are pro-atherogenic and others are not, and that's what that dotted line is showing. And so here is deep fried butter. And the center of this butterball contains cholesterol esters and triglycerides, and they're encased in a fried dough so you can carry it around in your hands. And that's exactly how this lipoprotein is structured. It has a hydrophobic core where the cholesterol esters and triglycerides are contained, and these are insoluble in water, so then they're breaded in a hydrophilic membrane of phospholipids and free cholesterol so that the lipids can be carried around in our blood. And we need to do that because cholesterol is used to build cell membranes, synthesize sex hormones and cortisol, produce vitamin D, also to make bile to digest fats. And then this swirl of mustard on the outside is an apolipoprotein. These apolipoproteins provide structure, they interact with lipoprotein receptors, and they're useful to help differentiate which lipids are atherogenic and how many particles of them we have. Because calculated LDL does not tell us a whole picture. LDL-C responds really well to traditional medication like statins, but this treatment actually only modestly reduces the risk of major adverse cardiovascular events, of MACEs. And a meta-analysis of 21 randomized clinical trials compared the relative risk reduction to the absolute risk reduction for patients using statins versus those not using statins. And they found that the absolute risk reduction was about 1% or less for deaths, myocardial infarction, and stroke. And to help demonstrate the difference between relative and absolute risk, imagine that your chance of having a heart attack in the next 5 years is 4.5%. So meaning if there were 100 people like you, 4.5 of you would have a heart attack. If you took a statin, that would reduce the risk to 3.2%. In relative terms, the relative risk reduction of your chance of having an MI, it's reduced by 29%. But in absolute terms, your absolute risk reduction, it's decreasing only by 1.3%. That's not very much. Since lowering LDL-C only modestly reduces risks, how can we go further in our risk assessment? Oxidized LDL activates macrophages and other cells, and it promotes endothelial inflammation. It contributes to atherosclerosis. Oxidized LDL is associated with MI, angina, metabolic syndrome, and hypothyroidism. Why does the LDL become oxidized? This can happen when diet, lifestyle, and toxic exposures are leading to more free radicals than the body's antioxidant defenses can handle. And then oxidative stress is the result. Dietary factors would include trans fat from margarine or fried foods, or hydrogenated oil in like Jiffy peanut butter, smoking cigarettes, vaping. This exposes a person to chemical irritants to the endothelium. These are the things that cause oxidation. And so this is how oxidation of LDL leads to atherosclerosis. The LDL receptors interact with the apolipoproteins to regulate liver uptake of LDL from plasma. Oxidation of the LDL modifies the ApoB 100. And initially it can still bind receptors, but this damaged ApoB 100 now causes the recruitment of inflammatory cytokines. And as it gets modified further, the LDL receptors can't recognize that ApoB. And that results in reduced clearance of the oxidized LDL from the bloodstream. Macrophages, though, they do recognize the apolipoprotein B100, and they can take up the oxidized LDL and they develop into foam cells. These foam cells accumulate on blood vessel walls and form plaques. Oxidized LDL plays a major role in endothelial dysfunction and atherogenic events. It promotes endothelial injury, it delays healing from this, it causes inflammation, foam cell formation, and it alters epigenetics. All of these are steps along the road to atherosclerosis. Next is small dense LDL. Why do we care about this one? You can have up to 70% more LDL particles if they're small and dense. The LDL-C does not tell you how many particles you have or what size they are. Even if LDL is in range, there still may be significant risk of coronary heart disease and arteriographic disease progression if small dense LDL is high. This is why size matters. The small dense LDL, which are the two categories on the right of this picture, can get more easily embedded into the endothelium of the blood vessels. And they lack antioxidant and can be more easily oxidized. And that initiates the onset and progression of atherosclerotic disease. When 4,100 patients with stable coronary artery disease were followed for 8 years, the highest quartile of small dense LDL was predictive of major adverse cardiac events in patients who had both high or low LDL-C. There's a positive association between small dense LDL-C and carotid intima media thickness and coronary artery calcium, meaning the worse your small dense LDL is, the thicker is the carotid intima media, the more likely there's calcification. And reducing the small dense LDL significantly reduces coronary disease risk. In fact, small dense LDL has been called the single best predictor of increased coronary artery stenosis. And if it's elevated, consider imaging. Doctors at Stanford found that runners had significantly less small dense LDL than people who don't exercise. You don't have to be a runner. Exercise is the key, and it should be regular. Therapies and lifestyles that decrease triglycerides will also affect small dense LDL in the same direction. For example, beta blockers actually increase triglycerides, and they also increase small dense LDL, unfortunately. And speaking of other treatments, if niacin is said to not decrease LDL, it's kind of true, but niacin can shift the distribution of LDL particle size, which is going to be more impactful. Niacin supplementation can result in 32% less small dense LDL and a 23% increase in large LDL. And combining niacin with fibrates can decrease the need for high dosing if your patient is on that medication. A good dose for niacin would be using extended release, 1 to 2 grams, fish oil, 3 to 4 grams per day. Lipoprotein a consists of an LDL plus ApoA covalently bonded to ApoB. And production of this is genetically determined. It's an independent risk factor for premature heart disease, thrombosis, and stroke. The National Lipid Association states that testing lipoprotein a is reasonable with a personal or family history of early onset atherosclerotic cardiovascular disease, or if the patient has LDL above 190. Lipoprotein a can bind to arterial endothelium and displace plasminogen. It interferes with fibrinolysis and it makes it harder to break down clots. It also accelerates platelet aggregation, and it promotes inflammation because it carries around the oxidized phospholipids. There's not much you can do for this marker, but it's important to be aware of your status, and then you can do everything else to decrease risk through other means, like optimizing the rest of the lipids, optimizing the lifestyle, and aggressively decreasing the LDL. Treatments that you might think of, so if you're lowering LDL with a statin, that's not going to lower the lipoprotein a, but you can slightly decrease this with diet and exercise, or if you have really high lipids to begin with, and then you decrease them to normal range, that might decrease this a little bit. Fish oil and niacin may be supportive. You're going to need multiple interventions though. One treatment that does work, unfortunately, is really inconvenient and is never done that I've heard of, lipoprotein apheresis. You filter the blood to remove the specific lipoproteins that you want to get rid of. It's really the only effective method, but it's not realistic. I do believe drug development is happening for this, but they're not there yet. LDL-C is reported in milligrams per deciliter, and that tells you what is the weight of LDL that you have in a certain volume of serum. But could you tell me how many balls are in this basket if you weighed the basket and you knew how big the basket was? You can't. But if you dump all these balls on a conveyor belt and you scan the barcodes, you're going to get a count of the total items. If the basket was full and it only contained 6 balls, then you could assume that these are really large, like beach balls. But if it contained 200 balls, then you could assume that most of them are really small, like golf balls or like small dense LDL. LDL-C does not distinguish between the more harmful small dense LDL versus the less atherogenic large buoyant LDL. Just like the weight of the basket didn't tell you the proportion of balls that are beach balls versus golf balls, but counting the number of items or particles gives you a better idea. Those barcodes represent the apolipoproteins, which you can measure to get a count of how many particles you have. Tons of particles is not good when they're the ones attached to apolipoprotein B100. It's the major structural component of the more malevolent lipoproteins, meaning LDL, IDL, VLDL, lipoprotein A. There's a single molecule of ApoB 100 on each particle of these lipids, and that allows you to determine the number of atherogenic particles. LDL, we oversimplify as the bad cholesterol, but that's not necessarily true. It takes cholesterol from the liver to the periphery, And we need to use that cholesterol in the testes to make testosterone, in the adrenals to make cortisol, and in the endothelium to patch up inflammation and damage. When you measure LDL-C, it's calculated by subtracting HDL and triglycerides from the total cholesterol concentration. If you test apolipoprotein B100, that will give you particle number. Recent international guidelines concur that ApoB is the most accurate measure of lipoprotein-associated atherosclerotic cardiovascular disease risk. The problem is when too much cholesterol is circulating in the blood and building up in the periphery. This creates plaques, and not enough is undergoing reverse transport to the liver. Reverse transport is when excess cholesterol from the peripheral tissues or plaques is removed and transported back to the liver to be degraded into bile acids. HDL is responsible for this cleanup process. It brings cholesterol from the periphery to the liver. That's why we call it the good cholesterol. Each HDL particle is wearing an apolipoprotein A1. ApoA1 is associated with decreasing inflammation. The balance between ApoB100 and ApoA1 represents the balance between atherogenic and anti-atherogenic disease activity. It gives us a general idea of the balance between cholesterol delivery and accumulation in the periphery versus reverse transport to the liver for degradation. A higher ratio of ApoB100 to ApoA1 is associated with the risk of coronary heart disease and MI. And modern research indicates that these ratios are all more sensitive risk markers than the traditional lipid panel. Elevated total cholesterol is more clinically significant in the context of a high total cholesterol to HDL ratio. So in general, all these ratios, lower is going to be better on these. Now that we've checked your oil, we should also check, is your car overheating, and take a look at fuel economy. That was my weak metaphor to transition to talking about inflammation. Oxidized LDL in the vascular wall is broken down by lipoprotein-associated phospholipase A2. Lipid-laden macrophages within the artery release PLAC, furthering inflammation, and calcified plaques can become unstable. So this test is measuring the activity of this enzyme that's derived from the macrophage. High PLAC indicates very significant atherogenic disease activity within the coronary arteries. It increases the risk for the rupture of advanced plaques, and you have increased risk of heart attack morbidity and mortality. This marker indicates twice the risk of coronary artery disease regardless of the HDL. Consider counseling your patients on diet and exercise and helping them reduce weight. You can also measure red blood cell fatty acids to see if they have enough DHA and enough EPA, because that will help decrease this marker. If ApoA1 is low, then measure CoQ10 in the red blood cells and supplement that if needed, and then lower those other risk factors. To put some of these biomarkers in perspective, I'm giving you this picture of the progression of atherosclerosis leading to acute coronary syndrome, and then which tests are associated with which point in the disease process. Oxidized LDL correlates with intimal thickening, and then plaque growth is likely happening once you see elevated HSCRP. If the plaque matures and then becomes unstable, then you'll have elevated lipoprotein, the LPPLA2. And if none of this is addressed, you could end up with plaque rupture, acute coronary syndrome, and then you might be testing troponin T in the hospital. Okay, and now, are you refueling more often than you should? How's your fuel economy? So that's the end of that metaphor. But just transitioning to talking about blood sugar regulation. Hemoglobin A1C tells you about the average blood glucose over the past 3 months, but it's not very sensitive to tell you about hyperglycemic excursions. That's where the 1,5-anhydroglucatol or the 1,5-AG comes in. It tells you if you've had blood sugar over 180 in the past 2 weeks. It's a more accurate predictor than hemoglobin A1C for predicting hospitalization with COVID-19. So this kind of tells you why low 1,5-AG tells you that you've had hyperglycemia. Glucose competitively inhibits the 1,5-AG resorption in the kidney tubule. And when glucose levels rise, even transiently, then you get urinary loss of 1,5-AG, and then circulating levels in the serum will fall. It's not super useful in evaluating gestational diabetes, but it can be a valuable complement to frequent self-monitoring of plasma glucose to confirm stable glycemic control. If your patient has low 1,5-AG, I would highly consider continuous glucose monitoring to figure out which meals are associated with that hyperglycemia or what time of day it was happening. Fat cells produce the hormone leptin to signal satiety to the hypothalamus. Leptin inhibits appetite, it stimulates thermogenesis, decreases glucose, and ultimately body fat. And levels in the blood are directly proportional to body fat mass, but 10% of patients living with obesity may have an inherited leptin deficiency. Also know that metformin and atorvastatin can lower leptin. Here is a preview of the cardiometabolic profile. So far, we've covered the more specific lipid markers, the ratios, and the metabolic risk indicators that might have been new to you. This profile also includes markers of kidney health. That's the last three on the bottom, the cystatin C, the creatinine, and then the estimated glomerular filtration rate. Cystatin C is produced by all nucleated cells. The kidneys regulate levels of this in the serum. Elevations in cystatin C reflect reduced renal function because the kidneys are not regulating the levels very well. And this is more predictive of progression to kidney disease and also MACEs and all-cause mortality. GFR, or glomerular filtration rate, is estimated using creatinine. This is a waste product made by the muscles. If you have a patient who is elderly or has certain comorbidities or high muscle mass, then creatinine levels may be altered, and that renders the estimated GFR less accurate. There was one large retrospective study that found that 27% of patients with chronic kidney disease would be restaged to a later stage of disease using cystatin C to estimate GFR, especially if they were elderly or if they had comorbid conditions. And cystatin C is less useful in patients who are taking steroids or if they have an untreated thyroid disorder. After all of that hypothetical discussion, now we're going to put the ideas into practice and talk about some patient cases. Our first patient is a 58-year-old female. She is on the ketogenic diet, eating a lot of burgers and cream. I don't see many vegetables in her diet. And her BMI is in the normal range. She achieved that on the ketogenic diet by losing some weight. However, she still has excess abdominal or visceral fat. She may have an inherited leptin deficiency that could help explain that low leptin. It would be great to do a body composition analysis for her to see, does she have a healthy amount of lean mass? And how much, what is her body fat percentage? Going back to the report, the LDL-C and the HDL are really bad. The non-HDL is highly suggestive of chylomicron remnants, and those are very atherogenic. She has high PLAC. She has elevated CRP. It's a very bad combination. She really is going to need to do some major dietary change. And the low creatinine could be consistent with really poor muscle mass. She needs to start exercising, and I would highly recommend resistance training. Her oxidized LDL, her small dense LDL, and her very high ApoB are significant red flags. And with the low 1,5 AG, remember that represents high blood sugar, she's at risk of developing type 2 diabetes. And the elevated non-HDL cholesterol is showing us that she has increased risk of coronary artery disease. And then the high hsCRP is telling us she has arterial inflammation. The increased small dense LDL and the oxidized LDL are likely contributing to plaque formation. And then LPPLA2 activity gives more evidence to that plaque formation and instability of that plaque. And her low insulin could be due to the presence of ketones, which is pretty likely with this kind of diet. Other reasons that you might see that low could be diabetes, less commonly hypopituitarism, cystic fibrosis, or chronic pancreatitis can cause that too. And while there's some evidence that ketogenic diet may improve a lipid profile, it's important to measure the real LDL culprits, as done here, and address the specific markers, see what the patient's risk actually is, and retest these markers in 6 months. Oxidized LDL in keto diets you can address by adding in foods that contain vitamin C that are still low carbohydrate. So that would be brassica vegetables like broccoli, bell peppers, strawberries. Olive oil contains polyphenols, which are associated with improved cardiovascular health and positive outcomes. When you see elevated oxidized LDL, prioritize the more oxidation resistant monounsaturated fats and then decrease the polyunsaturated fats because they're more prone to oxidation. And then don't forget about fiber. You can still have fiber on a keto diet, and I think it's really important to think about including that. Next person is a 51-year-old male who is on a standard American diet. I think we all know what this is, a lot of fast food, a lot of pizza. He has switched to drinking diet green tea instead of water because of health benefits, but I think we all know that the fake sweeteners in these drinks are not very healthy. Specifically, sucralose can promote insulin resistance and weight gain. He is on a torvastatin, also called Lipitor, and that's to address his high cholesterol. And he feels too tired to exercise, unfortunately. I wish he could get some energy. It looks like the statin is working as expected. The total cholesterol, the calculated LDL, these are in range. But if you look deeper, the LDL is being oxidized at a high rate. The low lipoprotein A1 and the adiponectin, he has higher insulin and leptin. We have insulin resistance and leptin resistance. His HDL is too low, making me suspect inflammation. And then PLAC, homocysteine, and CRP are trending too high. The low HDL and the ApoA1, we can think about omega-3, niacin, soluble fiber. We can decrease oxidative stress with things like yoga, melatonin, etc. Make sure he can exercise 150 minutes or more per week. Since he's so tired, I would start with 10 minutes a day and work up from there. His hsCRP, it's a well-documented clinical marker of cardiovascular inflammation. Normal is below 1, 1 to 3 is considered more moderate, and then high is over 3. Seemingly healthy people who have high hsCRP are 4 times more likely to have coronary artery disease. It's associated with the risk of future adverse cardiovascular events like heart attack, stroke, and death. If it's high, consider imaging like a CIMT or coronary artery calcium. Also, get blood pressure in range. Go to the dentist. Periodontal disease is associated with inflammation and atherosclerosis. Make sure your patient stops smoking, stops or really decreases drinking alcohol, exercises, and focus on whole foods, unprocessed foods, a plant-heavy diet. Statins can lower the hsCRP in patients with in-range LDL, and then doing this does reduce the risk of cardiovascular events. Improving the CRP is associated with a reduced rate of progression of atherosclerosis. Homocysteine can promote thrombosis through several mechanisms, including impairing endothelial function, increasing platelet reactivity, and affecting coagulation factors. Hyperhomocystinemia increases the risk of MACEs, and it also correlates with psychiatric illnesses. You can think about running a methylation panel to check if your gears are turning. You can recycle the homocysteine back up to methionine and support the enzymes that do that with the cofactors B6, B12, folate. Make sure those are methylated. It's going to be more effective. Consider testing glutathione status. It's probably not adequate. You might think about supplementing N-acetylcysteine. You might supplement glutathione. You can use supplements. There are also medications available like Deplin, which is prescription folate. Diet-wise, you want to think about legumes, citrus, leafy greens, rule out kidney disease and hypothyroid. Okay, so leptin, low levels, we talked about this. It's correlated with BMI. So low BMI, low leptin, high BMI, high leptin. Low levels could predict cardiovascular mortality because of increased rate of cardiac cell apoptosis. You really want leptin to be in range, not lower, lower, lower is better. High leptin, common in obesity. It normally decreases hunger by communicating with the brain that the adipocytes are full, but if the levels are too high for too long, you can get leptin resistance, and then that can make weight loss more difficult. Adiponectin On the other hand, it is healthy. It regulates blood sugar and insulin sensitivity. It helps with lipoprotein metabolism and triglycerides. It's anti-inflammatory, it is anti-diabetic, and it facilitates proper endothelial function. And if you have excess adiposity, then less adiponectin is released into the circulation. Low levels are associated with increased risk of developing type 2 diabetes and coronary artery disease. Lifestyle changes that decrease body fat can help mitigate the low adiponectin, and the associated consequences to metabolic health. Leptin adiponectin ratio. If it's high, it can increase the risk of metabolic syndrome, type 2 diabetes, cardiovascular disease, even more so than just abnormal levels of leptin or adiponectin alone. I made this mnemonic device to help you remember kind of which is which between leptin and ghrelin. Leptin means leave the table because you feel full. Ghrelin, give me more food. It stimulates hunger. If you have leptin resistance, the leptin is going up, but it's less effective. And that's what the elevated LAR is indicating. Leptin resistance is driven by insulin. The patient is not going to feel full after eating, and then the brain thinks they're starving, and there's decreased movement and fatigue. For elevated leptin, work on improving the body composition. It's really important also to decrease fructose consumption, and chronic stress also can contribute to high leptin levels. Think about increasing produce and fiber in the diet, exercising, and reducing body weight. Next case is totally different. This is a 66-year-old female. She's at the low end of the range for BMI, and she has had 2 strokes, and she's been put on blood thinners now to help prevent. Her lipids actually look very healthy, except for the lipoprotein A, which is that genetically determined lipoprotein. It's extremely high, and there's an association between this and ischemic stroke. Her oxidized LDL to total LDL ratio is high. She's oxidizing her LDL. And I'm really glad we tested this, because otherwise, if we had just looked at a traditional lipid panel, everything would have looked healthy and we would have thought, what more can we do? As far as the insulin, some say optimal is between 2 and 3. Hers is a little bit low. I kind of wonder if she's eating enough. Also, lower leptin is seen in patients with lower body mass. Lipoprotein a prevents thrombolytic activity, and it's associated with elevated risk of clots. The best thing we can do is focus on the other factors that we can control, like exercise, control the blood pressure, and aggressively lower the LDL. The lipidologists at OHSU are targeting an LDL below 50 for patients who are at high risk of atherosclerotic cardiovascular disease, who also have high lipoprotein A, possibly with family history. They often use statins like rosuvastatin or maybe pravastatin, and then add ezetimibe if needed to keep things under control. Niacin can lower lipoprotein a just a little bit, and there's also some evidence for aspirin just to use as a preventive measure, not that it changes the level of this marker. Last case we have, people might think that they're eating healthy, but this person is drinking diet pop and focusing on low fat. Low fat diet, as far as being healthy, that was kind of promoted in the 80s. But I don't think the thinking on that was very logical. There's really nothing healthy about this patient's results. Pretty much everything is wrong. We have high cholesterol, triglycerides, LDL, VLDL, non-HDL, the oxidized and the small dense LDL are high, the PLAC, CRP, ApoB, and then low HDL. The low adiponectin is showing us likely insulin resistance. The genetics look pretty good, low lipoprotein A, but this patient's poor lifestyle choices are contributing to all of these other out of range markers and ratios. ApoB is 194. We have lipoproteins that can contribute to endothelial inflammation and atherosclerosis. The elevated leptin to adiponectin ratio is likely indicating the excess body fat. And these results are significant. They require serious attention and lifestyle changes. And this patient could benefit from pharmaceuticals along with body fat loss, especially if there's family history, or if you think that the lifestyle change is going to take some time. So think about patient compliance when you decide to do a lifestyle approach, a supplement approach, or a medication approach. You want to think how compliant are they going to be? When you're addressing hyperlipidemia, diet is paramount. There are also numerous helpful supplements listed here and throughout the talk. I always like to promote Mediterranean style eating, having patients consume foods that are not processed. The NOVA classification system can help people categorize foods based on how processed they are. The standard American diet would be more on a classification 1, and then Mediterranean diet would be, Mediterranean is on 1, SAD is more of a 4. So 1 would be a whole apple, 2 is if you slice it, 3 is sauce, and then 4 is apple juice. That kind of helps you understand the range there. And then the other thing is, if you're talking about Mediterranean diet, the bottom of their food pyramid is having meals with others. This promotes parasympathetic mode. It improves saliva production and digestion, and then that helps lower your cortisol. Similar lifestyle changes here can also help address the elevated PLAC. NSAIDs also might be a consideration. And then red yeast rice, I do like using it, and I do see it help to some extent. Depending on how off things are, it's just good to retest if you're going to use that. 1,200 milligrams per day, include CoQ10 if you're going to employ red yeast rice. Statins can lower LDL-C more so than ApoB. It's really important to monitor this marker to make sure that your therapy is actually lowering risk like you expect it to. As far as statins, rosuvastatin or pravastatin are better choices because they don't cross the blood-brain barrier, whereas atorvastatin does. And when you get the statin into the brain, then you're reducing cholesterol synthesis there, and that can affect the pathogenesis of cognitive decline. 10 to 40 milligrams of rosuvastatin actually lowers the ApoB by 37 to 45%, and that is better than simvastatin or atorvastatin. Niacin can increase ApoB degradation in the liver, so that can also be helpful. If you combine a statin plus niacin, that can give you greater effects than just a statin alone. However, if you're already on a statin and you add a fibrate, that will not lower the ApoB anymore. And then if you combine 10 milligrams of ezetimibe with 40 milligrams of rosuvastatin, that was shown to decrease ApoB by 56%. And that was the most reduction that any of the studies showed. Adiponectin increases insulin sensitivity and it's cardioprotective. The levels are inversely proportional to body fat percentage. And if someone has low levels of this, think about weight loss, improving body composition, eating more plant foods, fiber, and then mono and polyunsaturated fats. And also include any therapies that you typically use to promote insulin sensitivity and decrease inflammation. There are plenty of things you can do. The cardiometabolic profile is explaining what is happening with the individual's physiology, but we also have smaller profiles that would be great to use if you just need to follow up on one section of these markers. The cardiovascular risk profile or just oxidized LDL can be a standalone test. You can reorder these profiles at 1 year. Because these markers take time to change, especially since lifestyle change really takes time when the patient is trying to form new habits or trying to stop bad habits. The metabolomic profile is assessing the risk of developing metabolic syndrome, and we include early detection of hyperglycemia, insulin resistance, leptin resistance, and also those markers of kidney health, all of which we discussed throughout the talk today. And metabolic syndrome increases the risk of type 2 diabetes and kidney damage and the risk of coronary heart disease. Detecting the development of this early is really important because patients don't always present with symptoms until the condition is advanced. And lastly, to take this test, it requires venipuncture. You need to be fasting for at least 6 hours for a number of these markers, and the turnaround time is about 5 to 7 days. Especially think about this for patients with a family history of cardiovascular disease. If the patient has visceral adiposity, if they are on a processed food diet, or even if they're on a ketogenic diet. I think this is a great test. And also if you already know that they have fatty liver or blood sugar metabolism issues. Additional considerations. One more thing to know, don't perform this test if the patient is acutely ill because that can alter some of the markers. Further considerations to round out cardiovascular health are listed here. I mentioned the GI 360 briefly because if you assess the gut microbiome and digestive health, that is really foundational because this affects your tendency to become overweight, how you absorb nutrients, how you resorb your lipids, and producing bile acids. So there are a lot of reasons to look at the GI 360. Also, toxic element testing comes into play because lead can contribute to increased blood pressure, and also accumulation of lead, cadmium, and arsenic can increase the risk of cardiovascular mortality and MI and stroke. One more thing would be looking at sex hormone balance when you're treating hyperlipidemia in men with increasing testosterone levels, then the lipid profile is less atherogenic. In women, increasing androgen levels are associated with lower HDL and higher triglycerides. So kind of the opposite effect for androgens for both sexes. And then thyroid function can really affect lipoprotein metabolism and then some of the cardiovascular risk markers as well. Even within a normal range of TSH, as you go up in TSH, then you're going to get lower HDL, higher triglycerides, higher LDL, higher total. And lastly, vitamin D can affect glucose metabolism. So these are some other things you want to look at if you're treating the whole person and trying to address everything that's going on. This resource guide is available on Doctors Data's website if you need a reference. And we have come to the end. Thank you for your attention and for listening. And hopefully I've gotten to all of your questions in the chat box by now. But if not, I will attempt to put together the answers in an email to any questions that came in too late for me to get to. And now I can take some questions now.